Well, when we talk about medical guidelines, I think we generally expect this absolute, unshakable, universal truth.
Right, like physics or something.
Exactly, like physics. Like,
Ugh.
gravity works the exact same way in Paris as it does in Tokyo. Drop an apple, it falls.
Yeah, it's a constant.
Right. And we naturally assume human biology is a constant too. We want the gold standard of care to just be the gold standard everywhere for everyone.
I mean, that's the ideal, for sure.
But then, you step into the world of global oncology and that universal rule book just completely gets thrown out the window.
Oh, absolutely. It's tossed right out.
Suddenly, the quote-unquote best medical treatment is completely dictated by where you happen to be standing.
Yeah, it is the ultimate collision of geography, biology, and, well, economics. And it forces us to really rethink what a standard of care actually means in practice.
Welcome to today's Deep Dive.
Hmm.
We are looking at a stack of incredibly dense but absolutely fascinating source material today,
Very dense, yeah. But so important.
for sure. Specifically, we're looking at a foundational medical document. It's called the Pan-Asian Adapted ESMO Clinical Practice Guidelines for the Diagnosis, Staging, and Treatment of Patients with Metastatic Breast Cancer.
Right, quite a mouthful, I know.
It really is. But our mission today is to kind of shortcut your path to understanding how cutting-edge global medicine actually works in the real world.
Right, because this isn't just a dry medical text.
Not at all. This is a story about why a treatment that saves lives in Europe might not be the standard in Asia. And joining me to connect all these complex dots is our resident expert.
Glad to be here.
And for those of you listening, you should see the backdrop our expert has set up today.
I figured we needed a visual aid.
It's amazing. It's this incredible high-tech glowing digital map of the globe. And it's perfectly overlaid with this complex genetic sequencing chart. It's like the perfect visual for what we are about to get into.
I thought it set the tone pretty well because, the stakes here are just immense.
Right.
Breast cancer is the most commonly diagnosed cancer worldwide. But the way this disease behaves on a cellular level and the way doctors are practically allowed to treat it varies wildly.
Wildly. Between Europe, the U.S., and Asia.
Exactly.
Okay, let's unpack this. Because to understand why a major European oncology guideline needed this massive Pan-Asian adaptation in the first place, we have to look at the raw data of who is actually getting sick.
The demographics are completely different.
Right. Using European breast cancer guidelines in Asia is, well, it's like using a map of New York to navigate Tokyo.
That's a great way to put it.
Like, the basic infrastructure of a city is there, but the traffic patterns, the neighborhoods, the literal biology of the tumors and the ages of the patients
Yeah.
are entirely different.
Yeah, what's fascinating here is the sheer scale of those demographic differences. That's what necessitates a completely new map.
So what do those differences actually look like in the data?
Well, if you look at Western populations, the peak age for a breast cancer diagnosis is around 70 years old.
Okay, 70.
But in Asia, that peak is significantly younger. It hits around age 50.
Wow, 50. That's a 20-year difference.
It's huge. And in Eastern Asia specifically, roughly half of all breast cancer patients are premenopausal.
half.
Yes, half.
Wow. If you were listening to this, just think about the biological implications of that for a second. We're talking about a disease that is heavily influenced and, often actively fed by hormones like estrogen.
Exactly.
And it's not just the age difference, is it? It's how aggressive the disease is on day one.
Right. The severity at presentation is a major divergence between the regions.
How so?
So in Europe and the US, only about 3 to 10% of patients present with what the medical community calls de novo metastatic disease.
De novo, meaning...
A Latin term. Yeah, meaning from the beginning. It means the very first time these patients find out they have cancer, it has already spread beyond the breast to other organs.
So only 3 to 10% in the West? What about in Asia?
In Asia, that number jumps significantly. It's between 2 and 25%, depending on the specific region.
Wow, 25% in some places. So doctors in Asia are dealing with a much younger population and a cancer that is often much further along the exact moment the patient walks into the clinic.
Exactly. But the map analogy goes even deeper because the literal biology of the cancer cells themselves is fundamentally different.
Okay, so the cells are actually different.
Yeah, our sources show that Asian patients have a notably higher incidence of a subtype called luminal B disease.
Okay, let's break that down for the listener. What exactly makes a tumor luminal B, and why does it matter?
Well, luminal B tumors are hormone receptor positive, which means they use estrogen to grow.
Right.
But they are characterized by the higher expression of a specific protein called Ki-67.
Ki-67.
Yeah, think of Ki-67 as a speedometer for cancer cells.
A speedometer, okay.
So a high level means the cells are dividing and multiplying very rapidly. And on top of that, these Asian patients show much more frequent mutations in the TP53 gene.
Oh, I've seen TP53 mentioned in other oncology literature. That's essentially the body's internal spell checker, isn't it?
Yes, that is a really great way to visualize it. The TP53 gene produces a protein that basically acts as a tumor suppressor. It is the brakes of the cell.
Okay, the brakes.
Right, so if DNA gets damaged, P53 halts cell division until the DNA is repaired, or it forces the damaged cell to just self-destruct.
That makes sense.
Yeah,
So what happens when it mutates?
when the TP53 gene is mutated, the cell loses its brakes, it loses its spell checker, it just multiplies recklessly damaged DNA and all.
Oh, wow.
Yeah, what this translates to in the clinic is a much more aggressive tumor, a worse overall prognosis, and crucially, a higher resistance to standard endocrine therapies.
So the European map says, take this standard route, use this standard endocrine therapy because the patient is likely 70 years old.
Right.
But the Asian patient's biology is essentially a massive roadblock on that route.
Exactly. What's fascinating here is how this younger, more aggressive biological profile completely alters the first line of defense.
How so?
Because so many of these Asian patients are premenopausal, right?
Right.
Their ovaries are still actively producing the estrogen that fuels the cancer's rapid growth.
Right. The factory's still open.
Exactly. And this is why the Asian Adaptation Panel was so adamant about something called ovarian function suppression, or OFS.
Okay.
The European guidelines were primarily geared toward postmenopausal women whose ovaries have, naturally stopped producing high levels of estrogen.
Right.
So the Asian experts had to look at that guideline and say, for our specific patients, suppressing ovarian function isn't just a secondary suggestion.
You have to shut down the factory.
We have to shut down the estrogen factory immediately. It is absolutely critical before we even start talking about other systemic drugs.
Right, because the biological map is completely different. The rules of navigation have to change.
Exactly.
Which naturally leads us to ask how a massive international panel of doctors actually goes about rewriting those rules. I mean, getting 20 people to agree on where to go for dinner is hard enough.
Oh, absolutely. It's a logistical nightmare.
Right, and here we have 20 voting experts from 10 different Asian oncology societies. We're talking China, India, Japan, Korea, Malaysia, the Philippines, Singapore, Taiwan, Thailand, Indonesia. How do they ever establish a consensus?
So they utilized a framework known as a modified Delphi process.
Modified Delphi process.
Yeah, it is a highly structured, iterative voting system. It's designed to strip away dominant personalities and find true expert consensus.
Okay, so nobody can just shout the loudest to get their way.
Exactly. But they weren't just voting on whether they generally liked a European guideline. They had to evaluate every single recommendation against two very strict criteria.
Which were?
Acceptability and applicability.
Okay, acceptability meaning, do we agree with the pure underlying science of this European recommendation?
Yes, exactly. Does the biological data hold up?
And then there is applicability.
Right, which asks, can we actually execute this in our region?
Logistics.
Yeah, like, is this specific drug approved by our local health ministries? Is it reimbursed by national insurance?
Do our hospitals even have the technological infrastructure to run this specific genetic test required to prescribe it?
Exactly. All of those real-world factors.
So what does this all mean? I have to push back here because this sounds like where the pure science collides with red tape.
It definitely has a collision point.
Right, because if the acceptability vote says a drug is the absolute best scientific option, but the panel downgrades the recommendation because of applicability, because of local government rules or economics, isn't that fundamentally dangerous?
I see where you're going with this.
Aren't we diluting the science and compromising patient care just to appease bureaucratic reality?
I completely understand the friction there, I do. But if we connect this to the bigger picture, you have to look at the reality of clinical practice. Knowledge is only valuable when it can actually be applied.
Okay, fair point.
A medical guideline that recommends a brilliant, unapproved, $10,000 a month drug to a patient in a country without access isn't medicine. It is science fiction.
Wow, science fiction.
Yeah, it does absolutely nothing for the actual patient sitting in the exam room today.
Okay, that is a sobering point. Because if a doctor in, say, rural Indonesia reads a gold standard guideline that only lists drugs they legally cannot prescribe, the guideline is basically useless to them.
Worse than useless, honestly, because they might just discard the entire document. The guidelines must reflect actionable reality to actually harmonize and elevate care across a region.
That makes a lot of sense.
Yeah.
So what's a concrete example of this clash from the sources?
Let's look at PRP inhibitors. These are brilliant drugs, like olaparib, which are incredibly effective for patients with certain genetic mutations, specifically the BRCA mutation.
Okay, let's make sure the listener's with us on the biology here.
Hmm.
The BRCA gene, much like TP53, is involved in fixing broken DNA, correct?
Yes. Your DNA breaks all the time just from living, and BRCA is one of the primary repair tools.
Okay.
So if a patient has a BRCA mutation, that primary repair tool is broken. The cancer cell is just hobbling along, relying entirely on a secondary backup repair tool called PIRP.
I see. So it's surviving on the backup.
Exactly. And a PIRP inhibitor drug comes in and destroys that backup tool.
Oh, wow.
Yeah, the cancer cell suddenly has 0 ways to fix its own DNA, and it dies. It's a beautifully targeted mechanism called synthetic lethality.
So if you have a BRCA mutation, a PRP inhibitor is basically a smart bomb.
That's a great analogy.
And the European guidelines basically said, if you have this mutation, go straight to the smart bomb. You do not need to force a patient to suffer through traditional harsh chemotherapy first.
Right. But the Asian experts pushed back on that.
Really?
Yeah, during the Delphi process, they softened the European language from a strong recommendation to a much weaker can be offered.
And this is the applicability issue. They downgraded a highly effective smart bomb. Why?
Because in major Asian medical systems, like in Japan, for instance, olaparib is strictly only approved for use after a patient has already shown resistance to traditional older chemotherapies,
Ah, red tape.
specifically drug classes called anthracyclines and taxanes.
And those are the old school hair loss carpet bombing chemotherapies.
Yes, they are highly toxic systemic treatments. But if the Pan-Asian guideline firmly said skip the harsh chemo, Japanese doctors wouldn't be able to follow their own regional guideline without violating their national drug approval laws.
Oh, I see.
The guideline would be completely inapplicable in one of the largest medical systems in Asia.
Got it. And reading through the sources, I noticed another fascinating divergence that wasn't about drug laws at all, but about hyperregional genetics.
You're thinking of the DPD testing.
Yes. The European guidelines strongly recommended routine genetic testing for a deficiency in an enzyme called DPD.
The DPD deficiency testing is a perfect example of why regional adaptation is mandatory. So the DPD enzyme is responsible for processing and breaking down certain types of chemotherapy in the liver.
Okay.
If a patient has a genetic mutation that causes a deficiency in this enzyme, those specific chemotherapies build up in their bloodstream and become fatally toxic.
Oh, wow. So testing for that deficiency before giving the chemo seems like an absolute no-brainer.
In Europe, it is a no-brainer, because that specific genetic mutation is present in a notable percentage of the European population.
Right.
But the Asian panel dropped that recommendation entirely.
Because it's an applicability issue again?
Actually, no, not because the European science is wrong, but because that specific genetic DPD deficiency is virtually non-existent in Asian populations.
Really? Non-existent?
Yeah, virtually zero.
Yeah.
So forcing Asian healthcare systems to spend thousands of dollars running routine tests on thousands of patients to find 0 mutations is a massive misallocation of medical resources.
Oh, wow. It is genuinely fascinating how local genetics dictate the global rulebook.
It really is.
But, while regional genetics and economics force guidelines to diverge sometimes, the source material also highlights this incredible moment where an undeniable scientific breakthrough was so powerful it forced the entire globe to fall in line.
Yes, the 100% consensus moment.
Exactly. I'm talking about a massive disruption that achieved 100% retrospective consensus among this entire Asian panel.
You are referring to the DESTINY-Breast04 clinical trial.
Yes. Here's where it gets really interesting. For decades, oncologists treated a specific breast cancer marker, a protein called HER2, like a simple light switch on the wall.
Right, the binary approach.
Yeah, it was either on and meaning you were classified as H2 positive, or it was off, you were HER2 negative. And that switch basically dictated everything about your future.
If you were HER2 positive, you received highly targeted, very effective anti-HER2 drugs that sought out that protein.
And if you were negative.
If your tumor was classified as HER2 negative, you were denied those drugs because the assumption was that they simply wouldn't work without a massive target to lock onto. It was a strict, unyielding binary.
But the DESTINY-Breast04 trial proved we were looking at the switch all wrong. It's actually not a standard light switch. It's a dimmer switch.
That analogy perfectly captures the paradigm shift. The trial investigated a new drug called trastuzumab deruxtecan.
Okay, trastuzumab deruxtecan.
Right. And what they discovered completely shattered the old rules. They successfully defined and treated an entirely new category of patients, which they called HER2 low.
HR2 low.
Mm.
So these are patients who, under the old light switch rules, were classified as HER2 negative because their tumors only expressed a tiny faint amount of the HER2 protein. The
Exactly.
light switch was barely glowing, so doctors just called it off and sent them to standard chemo.
Yes, but trastuzumab deruxtecan is a different kind of weapon entirely. It is what we call an antibody-drug conjugate, or an ADC.
The DC, okay.
Think of it as a microscopic Trojan horse.
A Trojan horse.
Yeah, so the trastuzumab part is a highly sensitive homing beacon that seeks out even the faintest glimmer of that HER2 protein.
It finds the dim light.
Exactly. Once it attaches to that dim light on the cancer cell, it gets absorbed inside, and then it releases the deruxtecan.
And what's that?
That is an incredibly potent chemotherapy payload, and it releases it directly inside the cancer cell.
Oh, wow. So it doesn't need a massive target. It just needs a tiny foothold to deliver the bomb.
Exactly.
And the implications of this are just staggering. If you're listening, think about the math here. Roughly 55% of all breast cancer patients who were previously told they were HER2 negative actually fall into this new HER2 low category.
Over half of them.
Over half.
Yeah, so overnight, you unlock a completely new, highly effective treatment path for millions of patients who thought they had exhausted all their targeted options and were basically facing end-of-line palliative care.
And the survival data from the trial was undeniable.
Completely undeniable. We are talking about a statistically significant improvement across the board. The median overall survival was 23.4 months for the patients given the ADC,
Wow.
versus 16.8 months for those stuck on standard chemotherapy.
That's huge.
In the world of advanced metastatic breast cancer, adding 6.5 months of survival is a monumental leap.
And this brings us back to that tension between science and regional economics, right? Because trastuzumab deruxtecan is incredibly expensive, and it certainly isn't approved or available in every single Asian country yet.
It isn't. But this is the moment where pure scientific efficacy overrides regional caution. The sheer weight of the survival data was so profound that the Asian panel had to give it a strong recommendation regardless of current applicability.
Oh, interesting. So they didn't downgrade it this time.
No, because the strategy here is that by cementing this drug in the Pan-Asian guidelines as the absolute standard of care, the guideline itself transforms into a battering ram.
A battering ram for doctors to use.
Exactly. Doctors can use this document to pressure their regional FDA equivalents and national health insurance boards to actually approve and fund the drug.
That is brilliant.
It really is.
Okay, so far we've spent our time exploring systemic drugs, chemotherapy, smart bombs, things that circulate in the bloodstream to fight a disease that is spread, but the panel also had to tackle local interventions, specifically the surgeon's role.
Yes, the debate over surgical intervention in primary stage IV disease. This was actually one of the most intense areas of contention between the European and Asian experts.
And this one requires us to really think about the mechanics of cancer. So if a patient comes into the clinic and they have a primary tumor in their breast, but the scans show the cancer has already metastasized, like it has already set up camp in their liver or their lungs or their bones,
Right?
do you still put them under anesthesia, put them on the operating table, and surgically remove the original breast tumor? I mean, logically, if you know the fire has already spread to the forest, why would you risk a major operation to put out the original campfire?
It's a great question. And the European guidelines were surprisingly broad on this front. They stated that surgery of the primary tumor, quote, may be considered.
Maybe considered. That's pretty vague.
It left a massive amount of room for individual interpretation by surgeons.
But the Asian panel vehemently pushed back on that. They demanded much tighter, highly restrictive language.
They did. They looked at the clinical data, specifically a study called the MF0701 trial, and realized that vague recommendations were actively harming patients.
Harming them.
Yeah. We have to look at the mechanism of the risk here. Surgery is massive trauma to the human body. If you perform a mastectomy on a stage IV patient, that patient requires 4 to 6 weeks of physical recovery just to heal the surgical wounds.
Right.
And what happens during those 4 to 6 weeks?
I mean, they're just healing.
Exactly. You cannot administer highly toxic, life-saving systemic chemotherapy to a patient whose body is actively trying to heal from a major surgery.
Ah, because the chemo would destroy their immune system and prevent the wounds from closing.
Precisely. So by stopping to stomp out the original campfire in the breast, you are forcing a 6-week delay in systemic treatment. That is 6 weeks where the forest fire, the metastasis in the liver or the bones, is burning completely unchecked.
Oh, well, that makes perfect sense. The delay is the actual danger.
Yes.
So the Asian panel specified that surgery should only be considered for very specific, narrow salvage scenarios. What are those exceptions?
They isolated 3 specific criteria. Surgery can be considered if the patient is younger than 55, if they have bone-only metastases, meaning the cancer has not yet invaded vital organs like the lungs or liver, and crucially, if they are already showing a strong positive response to their initial systemic drug therapies.
So you only subject them to the... It is a beautiful, endlessly complex dance. I mean, we started this deep dive thinking about medical guidelines as these rigid, universal laws of physics.
And they are definitely not.
No. What we've discovered from digging into this Pan-Asian adaptation is that effective medicine is anything but rigid. A tumor behaves differently depending on whose body it is residing in, and the treatment of that tumor is dictated by where that body is located on the globe.
Exactly.
Creating a true gold standard of care requires harmonizing perfect, cutting-edge cellular science with the biological reality of the patients and the stark economic and regulatory realities of the regions they live in.
Taking a broad global European guideline and painstakingly filtering it down through the realities of 10 different Asian societies undeniably created a vastly superior, far more accurate clinical tool for doctors in that hemisphere.
Absolutely.
But as we wrap up, there is one final provocative thought I want you to consider.
Please, leave us with something to think about.
We have spent this entire deep dive discussing the arduous transition from a global guideline to a continental guideline.
Right.
But look at the explosive advancements in genomic sequencing today. We now have the ability to map the exact, unique mutations of a single patient's tumor in days.
Yeah, it's incredible.
As that technology becomes cheaper and more ubiquitous, how far are we from a reality where there are no continental guidelines at all?
Oh, wow.
Where there are no national guidelines, where the future of oncology is a personalized medical guideline written exclusively for an N of 1U.
A completely bespoke rulebook of one. From Paris to Tokyo, down to the exact DNA sequence of the single person sitting in the exam room. The universal constant in medicine isn't geography after all, it's the individual.
I love that. Thank you so much for joining us on this deep dive into the source material.